Initial glaucoma treatment study, a comparison between laser and surgery, that was the advanced glaucoma intervention study, and also the tube versus trabeculectomy study. Now the CIGTS was a newly diagnosed open-angle glaucoma. That was at visual field loss and the quality of life, and the secondary outcome was visual acuity, IOP, and cataract formation. So we were to look at the visual field mean deviation by time. We see that there wasn't much difference between either the medical or surgical group, but significantly over here we noticed that at around the 8 years there was a 3 decibel decrease in the mean deviation of the visual fields. About the fear of blindness, the second question which they asked, they found that the initial treatment assessment, either medical or surgical, was not associated with fear of blindness. The most significant correlate over time of fear of blindness was the perceived impact on an individual's ability to perform a visual task. They also looked at medical versus surgical and the quality of life associated with it. They found that the quality of life was better with medical treatment, whether they looked at the symptoms with health problems, the symptomatic visual functional problems, or the local eye problems. When we looked at the IOP mean across the 2 treatment groups, the surgical group had a 48% decrease in intraocular pressure as compared to 35% in the medical group. This was statistically significant both from 2 to 9 years. The probability of cataract extraction was also higher, around 17% in the surgical group as compared to a 6% in the medical group. The surgical group also had more loss of visual acuity, even with adjustments for cataract-induced loss. About the trabeculectomy complications, other than cataract, there were bleb-related complications, which were the bleb revision in around 15%, and bleb-related complications like blebitis and hypotony in around 10%. Endophthalmitis was seen in around 1%. So to summarize the CIGTS study, we did have an initial decreased loss of visual field, initial decreased vision, lower IOP, more cataract, and more ocular side effects with surgeries. There was an AGIS survey which asked specific questions to all the glaucoma specialists, and from the responses they got, there were 3 questions which were asked. 1, are you more likely to perform surgery as an initial treatment for patients with moderate to severe glaucoma? Nearly 55.4% said no. They wouldn't perform surgery as the initial treatment. Are you more likely to counsel patients about the risk of cataract after trabeculectomy? Nearly 53% said yes, they would, and nearly 53% also said that their clinical practice has been significantly impacted by the CIGTS study. So what are our clinical implications? The implications are, we do not need to alter our current medical practice. We need to use the target intraocular pressure approach, where the visual field progression in both the groups was similar. Surgical treatment did cause more intraocular pressure drop. Advanced disease may benefit from early surgery. Exceptions are diabetics and African Americans. Fear of blindness is common, and when you newly diagnose a patient, you are supposed to reassure and tell him. Then we move on to the next, that was laser versus surgery. This was the advanced glaucoma intervention study, which compared argon laser trabeculoplasty with trabeculectomy. They were randomized into 2 groups. The ATT, where argon laser trabeculoplasty was done first, followed by trabeculectomy if that failed, and the TAT group, where trabeculectomy was followed by ALT if trabeculectomy failed. The outcome measures were again visual acuity and visual fields, and the secondary were IOP, complications, time of treatment failure, and adjunctive medications. They also compared the outcomes based on race. So when we look at the 10-year outcomes, and if you look at the whole group of patients, you would see that the average percentage of eyes with decrease of visual fields in the first 5 years was lower in the ATT group, but as it went beyond 5 years, the TAT group had lower field progression. Whereas if you look at the decreased visual acuity, the ATT always had lesser visual acuity loss as compared to the TAT group. In black patients, it was nearly the same, whereas in white patients, when we looked at the visual fields, there was a statistical significant bit lesser progression of visual field at 10 years in the TAT group. The visual acuity in the ATT group was always better than that in the TAT group, and in black patients it was visually significant through all the 10 years, whereas in the white patients it was significant only in the first year. If we look at the intraocular pressure change, the TAT group had lower IOP, but the difference in each of them was not statistically significant. The probability of cataract extraction was also higher in the TAT group as compared to the ALT group. As to what were the risks of cataract related to these complications, inflammation was the only one which showed statistical significance. If you had higher inflammation, your incidence of cataract was higher in the TAT group. And if we looked at IOP with visual field loss, they were divided into two groups. Those with intraocular pressure less than 18, they had no progression as compared to groups who had intraocular pressures always 50 to 75% or less than 75% of the times less than 18 millimeters of mercury. So what do we learn from the AGIS study? We learned that the relationship between low intraocular pressure and visual field loss remains an important finding. Lower IOP causes lower progression. In advanced glaucoma, lowering IOP to low teens means most will not progress. IOP fluctuation can have an important damaging effect, and cataract surgery is a side effect of glaucoma surgery. Risk factors, younger age and higher pre-intervention IOP, these increase the failure rate of both ALT and trabeculectomy. Trab failure is associated with diabetes mellitus and post-op complications, which are elevated IOP and marked inflammation. Cause of sustained decrease of visual fields in the ATT group was a male person and a worse baseline acuity, and in the TAT group it was diabetes at baseline. So we again go to the American Glaucoma Society survey. 3 questions were asked. Will you consider patient race initially in the treatment plan? Nearly 48.7% said yes, they would. Would you give greater consideration to diurnal variation after reading the AGIS study? Nearly 66% said yes, they would, and 70% said that their clinical practice has been significantly impacted by the AGIS. So in conclusion, yes, the cataract formation, the 5-year probability is increased to 78%, and if with a trabeculectomy after the first trabeculectomy, and if you had a second trabeculectomy, the risk is increased 3-fold. Initial trabeculectomy retarded progression more effectively in Caucasians than Afro-Americans. Long-term visual function outcomes are better for the ATT sequence in black patients and better for the TAT sequence in white patients. Some patients progress despite low IOP, and some retain high IOPs despite multiple interventions. We then move on to the tube versus the trab. This was a multicentric randomized clinical trial to compare a tube, that's the 350 millimeter square barbell, to trabeculectomy with mitomycin C in eyes which have had previous cataract and or failed glaucoma surgery. The main outcome measures were the IOP, visual acuity, visual field and surgical complications, and treatment failures were also looked into. The intraocular pressure in the first year was lower in the trabeculectomy group. However, the tube shunt was, but through the 5 years they evened out. Tube shunts were associated with more glaucoma medications than trab with mitomycin C during the first 2 years. This equalized with longer follow-ups, and trab with mitomycin had a higher failure rate as compared with the tube shunt surgeries. The probability of failure as seen here is more with the trab group. They also had higher reoperation rates. The vision loss was similar in both groups. Early post-operative complications were more with trab, but late post-operative and serious complications were similar in both groups. If we look at the failures of trabeculectomy with the TBT study, we'll see that the rate of failure was 10% every year. But at 5 years, the trabeculectomy had close to a 50% failure rate as compared to a 30% failure rate as seen in the TVT study. So the tube had a higher success rate than TRAB at 5 years, and the mean IOP number of glaucoma medications was similar at 5 years. So does that mean the tube is superior to TRAB? Well, no. TVT does not demonstrate clear superiority of any one glaucoma operation over another. Cost analysis cumulative expense is greater with the tube shunt. There is no significant difference between the two surgical procedures were observed in IOP at 3 months, medications used after 2 years, vision loss, rates of late post-operative complications and serious complications. In the AGIS survey, they asked them 3 questions. Are you more likely to perform a tube shunt instead of repeat TRAB with mitomycin C in eyes with previously failed trams? 58% said yes. Are you more likely to perform tube shunts instead of repeat TRAB with mitomycin C in eyes with prior cataract surgery? 50% said no, they'd like to do a TRAB with mitomycin first. And nearly 60% said that their clinical practice has been significantly impacted by the AGS survey. So, well, it's difficult to translate clinical results of randomized controlled trials into clinical practice. You need to individualize. It's also look at the surgeon's preference. TVT just does support its use beyond just the refractory glaucomas. The primary tube versus TRAB study is a new RCT which is used to answer whether we should use it as an initial surgical procedure. They're looking at IOP as the primary outcome, and complication rates, visual acuity, visual field, reoperation and supplement medical therapy as the secondary outcomes. It's due for completion in 2016. So we do know that evidence-based medicine does give us the best evidence to how we should put this into clinical practice. But I'd like to quote this from the D. Modis's article in the Journal of Glaucoma, that a large gap nevertheless remains between the questions we asked in the applicability of information provided by the RCTs to daily practice. Lessons learned from major RCTs should be analyzed cautiously from the clinician's perspective. Collaborative, multicentric, practical clinical trials should help define the extent to which the findings of rigorous selected populations can be extrapolated to diverse clinical practice populations and to help answer new questions that may arise in medical practice. And thank you for attending the session, and thank you for your listening.